Hello, this is Bill Nelson here with the entire American Association for Cancer Research webinar team, and we'll get started in just a few minutes. In the meantime, please take a little time to answer the poll questions we developed. We'll share the answers just after we get started. Good afternoon, it's Bill Nelson here along with the American Association for Cancer Research webinar team. We'll get started in just a few minutes, but please take a chance and look at the poll questions we've developed and provide some answers. We'll share them with all of you just after we get started. Hello, it's Bill Nelson here with the American Association for Cancer Research webinar team, and we'll get started in just a couple of minutes. Please take this opportunity, if you can, to look at the poll questions we developed, give us some answers, and we'll share those answers with you just after we get started. All right, I have 1 o'clock. Let's get started. Hello and welcome to today's webinar, Progress and Promise Against Cancer, hosted by the American Association for Cancer Research and Cancer Today. I'm Bill Nelson, Editor-in-Chief of Cancer Today and Director of the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. I'm both a physician and a scientist. The American Association for Cancer Research, also called the AACR or AACR, is the world's first and largest cancer research organization, bringing together the greatest minds from across the world in the quest to cure and prevent all cancers. Cancer Today is the AACR's magazine for patients, survivors, and caregivers. We're excited to be hosting this webinar today to provide you with some of the highlights of the AACR Cancer Progress Report for 2018. This report was released just last month, and today we can share with you an overview about medical research funding, about science policy, and about how you can get involved. You'll be hearing from two very accomplished experts. Dr. Elizabeth Jaffe is president of the AACR and chair of the Cancer Progress Report 2018 Steering Committee. She's also a close colleague of mine as the deputy director of the Hopkins Kimmel Cancer Center. Roy Herbst is the chair of the AACR's Tobacco and Cancer Subcommittee and has served also on the report steering committee. Dr. Herbst is the chair of medical oncology at Yale University. We'll also today hear from Mike Delia, a patient advocate who has been featured in the Cancer Progress Report. During these presentations, you are welcome to ask questions. You can submit them in writing in the webinar's toolbar on the right side of your screen. There will be two question and answer sessions. The first will occur after Mike Delia's presentation, the second after Dr. Herbst's presentation. I'm sure we won't be able to answer every question, but we'll try and get to as many as we can. Finally, before we get started, there are two items I want to mention. Our webinar is designed to be educational. Nothing in the webinar, nothing you'll hear today, is intended to be or should be construed as medical advice of any kind. Also, the opinions of the presenters are their own and do not necessarily reflect those of the AACR. Now let's share our poll results. The first question asks how you describe yourself so we know who's watching today. Here are the results. You can see that a number of you work in the healthcare field or treat cancer patients, and there are a number of others involved as well. The second question asked, thanks to cancer research, the number of cancer survivors is increasing year after year, a wonderful thing. How many cancer survivors are projected to be living in the United States by the year 2040? The answer? C, 26.1 million. And that's something you can read about in the Cancer Progress Report for 2018. Now, to start us off, I would like to introduce AACR's president, Dr. Elizabeth Jaffe. Dr. Jaffe is going to share highlights of a look at cancer progress in 2018. Dr. Jaffe.
Thank you, Dr. Nelson. Good afternoon, and thank you for joining us to hear highlights from the AACR Cancer Progress Report 2018. Next slide, please. This is an incredible, exciting time in cancer research. Both the rapid pace and the broad scope of the progress we are making are simply extraordinary. Scientific discoveries have allowed us to develop better ways to prevent, detect, diagnose, and treat cancer. Just consider the progress we have made in the past quarter century. If you take a look through this report, you'll find that between 1991 and 2015, cancer death rates fell by 26%, which equals 2.4 million lives saved. This amazing progress was a result of decades of research, and it's only through more research that we're going to continue to make further progress. Next slide. While no means the only measure of success, the report documents the significant progress we are making year after year against cancer by highlighting the medical products that have been approved by the FDA over the 12-month period. Consider the snapshot of just 1 year between August 2017 and July of this year. The FDA approved 14 new treatments against cancer, new uses for 11 previously approved anti-cancer treatments and 1 new surgery guiding system. Since the report was completed, more treatments have been approved by the FDA. We continue to hear more and more each month, and this is highlighting that we are constantly making life-saving progress. Development of these new tools for cancer treatment is possible because of the tireless work of individuals across the spectrum of cancer research. This includes basic researchers, translational researchers, clinical researchers, public health workers, and cancer care givers. It is also possible because of cancer patients themselves, and this is very important. These patients are willing to participate in our clinical trials. These trials play an indispensable role in advancing progress against cancer. Next slide. Among the most exciting recent advances against cancer is the emergence of 2 entirely new types of cancer treatment, targeted therapy and immunotherapy. These are often used alongside the 3 long-standing pillars of cancer care that include surgery, radiotherapy, and cytotoxic chemotherapy. Just last week, the Nobel Prize in Medicine was announced and awarded to a good friend of mine, James Allison, and also to Tasuku Hanjo for their basic science research in immunotherapy. Pictured here is Jim Allison. Coincidentally, the AACR was a joint sponsor of an immunotherapy conference, which I co-chaired, that occurred on the same day as that announcement. Dr. Allison happened to be attending the meeting, and here he is speaking with the media in this picture. Being an immuno-oncologist myself, I will focus my remarks today on progress in the area of immunotherapy. Next slide. So this slide shows some of how we think about immunotherapy today and how we are able to use these aspects of the immune system to fight cancer. Immunotherapy refers to treatments that work by unleashing the power of a patient's immune system to fight his or her own cancer. Much like it fights viruses, such as the flu or the common cold. Not all immunotherapies work in the same way, but several different types of immunotherapy are having dramatic effects in patients with certain types of cancer. One of the most exciting developments is that many cancer types can be treated effectively by the same agent. Patients with late-stage disease have experienced long-lasting responses, and this provides more patients with longer and, importantly, healthier lives. Next slide, please. In the past decade, the number of immunotherapeutics that are approved by the FDA to treat certain types of cancer has increased almost 5-fold. This is really exceptional. We have not seen this kind of progress since the history of developing new therapies for cancer. And the number of cancer types that can be treated by at least one immunotherapeutic has more than tripled. Highlighted are the cancers for which the FDA approved immunotherapies on this particular slide. This number keeps growing rapidly. CAR T cells are another form of immunotherapy which uses a patient's own T cells to attack and kill his or her cancer. Certainly CAR T cells are approved for a number of different cancers, but mostly blood cancers like acute leukemia and lymphoma. This therapy is helping to keep young and older people with these bad cancers alive and well for many years. In all cases, patients receiving CAR T cells had gone through all other therapeutic options and had nothing left to try. But CAR T cells turn this around for these patients. You can read about Mike D'Elia's journey in this report, and he will also speak to us a little later in this webcast. He is a survivor who benefited from immunotherapy. Next slide. The other group of immunotherapeutics that are highlighted in this report are called checkpoint inhibitors. These work by releasing the brakes on the cancer-killing power of our immune system. This work started in the 1980s by many basic scientists who wanted to better understand how to turn on and off the immune system. If we could control the immune system against viruses and bacteria, which is what the immune system was originally designed to do, then maybe we can control it to fight cancer. At least this is what these scientists were thinking in the 1980s. As you can see from this slide, the gene encoding the first signal that turns T cells off when they enter a cancer was cloned in 1987. This signal, called CTLA4, was then shown by Jim Allison, my colleague and friend who won the Nobel Prize, that it's possible to use an antibody to prevent turning this T cell off. Well, why is this important? Well, this antibody then allows this T cell to recognize and kill the cancer. And this is how these checkpoint inhibitors work. So it took years of mouse studies, as you can see from this slide, and then human studies to finally prove that it can kill, on a reliable basis, cancers in patients. The FDA finally approved this antibody against CTLA-4 in 2011. This was the first antibody or checkpoint antibody approved for the treatment of cancer. And I have to be honest, this was the start of the immunotherapy revolution. Next slide. Some of the enormous progress described in the report is highlighted by very personal stories of patients like Mike, who are not only alive today, but who also have a high quality of life, thanks to new and improved cancer treatments. In the United States, more and more people are surviving longer after cancer diagnoses. In fact, the number of cancer survivors in the country has grown to 15.5 million, and is projected, as you learn from the survey, to continue to grow quickly. Next slide. Because people are living longer after cancer, or with cancer in a more chronic form, we need to invest in more research to identify ways to improve the quality of life for patients and survivors by minimizing the risks of short-term and long-term side effects from cancer treatments, which are shown here in this slide. We must ensure that the exciting new treatments we are developing confer maximal benefit and minimal risk. We also need to consider how we are using the current therapeutics so that they can be employed in ways that give patients the best possible quality of life for the longest possible time. Next slide. So I want to thank you all for tuning in to my part of this webinar. And this will conclude my summary, and I will be happy to take questions at the time that we open it up to questions. Thank you.
Thank you, Dr. Jaffe. If any of you attending this webinar today would like to take a closer look at the report that she just described, you can go to www.cancerprogressreport.org, where you can read it digitally or you can request a hard copy. And now I'd like to introduce you to Mike D'Elia, one of the survivors featured in this year's Cancer Progress Report. Mike.
Thank you. Good afternoon, everyone. I'm honored to be a member of the panel today and to be able to relate my story and a few thoughts I've had from my experience with cancer. I trust you can all hear me out there from my basement office in Kennebunk, Maine. So, my name is Mike D'Elia. I'm 74 years old and recently retired from a couple of careers, one in the Air Force and another 25 years working in the business side of the defense industry. I might mention here that I served during the Vietnam War in Southeast Asia, where I was exposed to Agent Orange, which the VA has recognized as a probable cause of my non-Hodgkin's lymphoma. Next slide, please. So this is an interesting line on the top of this slide. Our sons refer to me as a genetically modified organism. And it's sort of a minor joke around here. But anyway, during the fall of 2013, while training for the upcoming ski season, I noticed a small lump in my thigh, in my upper right thigh. We originally thought it was just an aggravated cyst that had been aggravated during the exercises. But after 2 or 3 months, the size of a marble became the size of about a small potato. And I realized it was not just an aggravated cyst. So we had it diagnosed. It was large B-cell lymphoma, and I was at stage 3. So we started what became 2 rounds of chemotherapy in 2014 and 2015. Each time it seemed to go into remission, but it came back both times. And then we hit it with some radioactively, and the remission came back again. It became rather obvious after these 3 treatments that I had an aggressive cancer that was not going to be controlled by standard treatments. So my specialist, my oncologist up here in New England, cancer specialist, referred me to the Dana-Farber Cancer Institute. I was enrolled in a clinical trial for CAR T-cell therapy. My cells were collected, re-engineered in a lab in California, and sent back after 2 weeks to be infused into me in July of 2016. Since then, I've received a PET scan every 3 months for 2 years, which indicated no cancer, and so far I remain cancer-free. Next slide, please. With my experience, I believe there are a few things we can do for people who contract cancer or to advance cancer research. First, in my case, I feel very lucky that my oncologist in Maine had an ongoing dialogue with oncologists at the Dana-Farber Cancer Institute in Boston and knew of the ongoing clinical trial for CAR T therapy. But it shouldn't just be a matter of good fortune. I believe we need to get the word out to the general public of the newly available treatments and the ongoing research. Secondly, I had to put my entire faith in my care team. During my preparation and treatment, I was introduced to many new terms such as leukapheresis, cytokine release, with its potentially severe side effects. All of this was a potentially scary scenario. So my point here is we need to continue to look for ways to give patients as much knowledge and insight as possible during the process. Finally, I believe we need cancer survivors need to become advocates. I believe that these are especially exciting times for cancer research, and I feel incredibly fortunate to be living today. As Dr. Jaffe pointed out a few minutes ago, successes in the past few years appear to be increasing exponentially. As a patient advocate, we have a role to play. It's up to us to get the word out, especially to help inform our legislators. With this, I hope I've been able to relate a suitable story of success and trust in the future of cancer research. That's it for me. Thank you very much.
Mike, thank you so much for your story. It's incredibly inspiring. And thank you also for your insights on what it's like to participate in cancer clinical trials and to become a genetically modified organism and cancer survivor. Now we're going to have a chance to take some of your questions and answer them as best we can. As a reminder, you can submit questions in writing in the webinar's toolbar on the right side of your screen. And while we're waiting for some of these to come in, I thought I might start by asking Dr. Jaffe a question. The new results, the new findings with immunotherapy that you outlined are extremely exciting. How are we going to build on these to extend their benefits to more and more people who develop cancer in the future?
There we go. Dr. Nelson, that's a really important question, and there are many efforts ongoing. Some are ongoing already in patients where we are combining some of these very active agents because they can actually work together to fight cancers. And we're seeing this in cancers that were not responding to single agents, such as pancreatic cancer and colon cancers that you wouldn't expect to respond to single agent. In addition, there's a lot of research that is ongoing. We need more basic research to be able to better understand how these are working, how some patients are resistant to these agents, and what do we need to do to make those patients who are resistant more sensitive to these agents.
One quick question to start off for Mike Delia. You heard presented in the report that the AACR has been thinking about how many cancer survivors there are, how many we expect to see in the future, and what their unique needs will be to improve their health and quality of life. From your perspective, whether it's the psychological stress of having an illness, the way that a cancer diagnosis affects not only a person, but their entire family and friends and network, or health problems going forward, what do you see as the big challenges in cancer survivorship research moving forward?
Well, one of the questions that I've had is, how long does this last? I mean, I have what one of our sons called the good cops inside of me now, fighting all the bad guys. So how long do the good cops keep their energy up? Do I have to get a booster in the future? Do I need something in the future if this doesn't last, or can something be done again? These are the thoughts that go through my mind as a survivor, and wonder what will happen in the future.
So now we can turn to some of the questions as they've been coming in. One of the questions, although people appear to be doing better with cancer when diagnosed, the cancer incidence still appears to be increasing. What does the report have to say about that, Dr. Jaffe?
Yes, so some cancers continue to increase while others are decreasing or are being detected early. The cancers that are increasing, it's a complex situation, but we explain that in some cases we still don't have good early detection methods. And again, that's an area of very intense research right now. In other cases, there are environmental factors that are associated with this increase, such as in liver cancers. We're very concerned that liver cancers are rising, not because of viral infections, which was the original cause of many of these instances, but because of obesity and other environmental and nutritional problems that patients with these cancers have had.
And a follow-on to that, as cancer appears to be more common among people as they get older, and the population of people reaching older ages is increasing, do you see the need to treat people with cancer in their 60s, 70s, and 80s as an increasing challenge for cancer medicine and cancer research?
That's a great question. I think you're absolutely correct. Older patients have other needs. They have comorbidities, other kinds of medical problems, and this is becoming a specialty. I think we need to treat patients with cancer. Patients live into their 90s with full lives, so we need to treat older patients with cancer, but we have to be careful and gear our treatments to these patients because their biology may be very different.
A question for you, Mike Delia. How can we improve the diversity of participants in cancer clinical trials?
Maximum exposure. I've written to my congressman and congresswoman to make sure that we get the word out, not only to the general public, but especially, since I have a background in the service, to many of the veterans coming back from the different areas in the world where we're at war right now. It's very important. I think we're going to see a lot of illnesses, including cancer, increase as these soldiers and sailors and airmen come back, and we need to get the word out to them that there are cures or potential cures out there. But I guess what I'm trying to say is to get the word out to as many people and professionals as we can about the research. Did I answer the question? I'm not real sure.
No, I think you did. And, one argument is to have people more aware that clinical trials are available when one gets a diagnosis of cancer. There was a report out just within the last week or two about surveyed attitudes to clinical trial participants across all of medicine, not just in cancer. And it was amazing what fraction of people had completely dissociated the idea of participating in a clinical trial from their own medical care. It was sort of, I'm going to participate in medical care or I'm going to participate in a clinical trial. They didn't see those two as together, which obviously is the story for people like you who have participated in clinical trials for cancer. So another question that actually both of you can tackle a bit that's come in, which is as cancer research is starting to pay off with new opportunities, new approaches to cancer treatment, and hopefully to cancer prevention, is the cost of the newly developed products starting to become burdensome to cancer medicine? And was there attention to the growing cost of cancer care in the report? And then that's to Dr. Jaffe, and then after to Mike Delia. Is financial considerations, are they becoming more and more important as people make decisions about their cancer care?
Yes, that's a very good question. We're all very concerned. Physicians are concerned, caregivers. It's a national concern that the cost is way too high, and it's a big burden on patients, even patients with means. It's also a reason why many people may not have access to these drugs. We do talk a little bit about that, and the AACR has a very strong lobbying group in the DC area, and they talk about this issue along with many other issues in support of trying to get drugs more easily available and to more patients.
And so, Mike, from your perspective, as someone who's been through the journey of cancer treatment and now as a cancer survivor, are financial considerations things that are forcing people to make choices that aren't necessarily in the best interest of their outcomes?
I believe they are. With me, again, I was very fortunate because most of the cost, and I had asked early on what the cost would be just out of curiosity, because I was told that most of it was being taken care of by the laboratory in their investment in the research. So it wasn't personally a burden on me at the time. But when it was all done and I realized how much it did cost, I was very concerned about the average person and how they would be able to pay for it. I was concerned if insurance companies would pick it up. I was told that Medicare has approved my CAR T therapy, and that would go a long way to getting other insurance companies to pick it up, but it's always been a concern, and I'm not sure we're there yet on who and how it's going to be paid for.
This is clearly going to be a challenge moving forward. Another question that came in was, in addition to immunotherapy, we've heard about two very exciting approaches, the CAR T approach that Mike Delia benefited from, and the immune checkpoint inhibitor for which a Nobel Prize was just awarded, or Nobel Prizes were just awarded. What other kinds of new types of cancer treatments are highlighted in the report?
So I think we focused more on what was showing progress during this past year, but I can tell you that there will be new things coming forward in the near future, and these will be antibodies that are activating the immune system. So the current ones are inhibiting signals that are on these T cells, removing the brakes, but we also need to accelerate the T cells. So there'll be agents that will be probably approved over the next year or two. Then there are other subsets of immune cells, such as natural killer cells, and there's a lot of work being done in that area. I think over the next few years, what we see is combinations of the current agents and some of these newer agents that are in early clinical trials being approved. So that's where we have highlighted progress for the coming years.
Another interesting question that's popped in is, what about the role of exercise and rehabilitation in the care of people who are cancer survivors? And I would ask Mike Delia, did you pursue any kind of dedicated exercise or specific rehabilitation program at any time during your treatment? And do you imagine as we move forward that these types of interventions would be something you might want to participate in a clinical trial of, even as a cancer survivor?
Absolutely. That's an excellent question. I might start out with a little quiz here for most people. Does anyone know out there, if you're familiar with the expression, what are the three worst words in skiing? Well, the three worst words in skiing are follow me, Grandpa. I have 8 grandchildren, and 5 of them are doing black diamonds. So what I'm trying to say is I had to do extensive exercise and training just keep up with the grandkids. I feel extremely fortunate at my age, and when I was diagnosed and went into the CAR T therapy, I was 72 years old, and I was paying attention to the last answer very much, because I think I'm one of the older people that was allowed into the therapy, the clinical trial. I credit the fact that I've tried to keep in good physical condition all my life, but especially the last couple of years, and the fact that I stayed extremely active for my age. I feel without that, number one, would I've even been accepted into the trial, and number two, whereas I had very few side effects from the CAR T therapy other than some high fever the first 2 days after the infusion, I feel that if I wasn't in the condition I was in, I would not have been as fortunate. I think that answers the question.
It does. It also sounds like you're advocating for the use of grandchildren in improving outcomes, that they're as effective as any of our survivorship exercise and rehabilitation maneuvers so far. We're down to a last question, which I may throw at Dr. Jaffe. We've heard from Mike Dealey about how effective some of the early versions of the CAR T cells are, particularly against lymphomas and acute lymphocytic leukemia and the like. Do you imagine we're going to start to see CAR T cells for major solid organ cancers, colorectal cancer, pancreas cancer that you know a lot about and the like? What's going to happen there? I'll let you predict for us.
Yes, that's an excellent question as well. All good questions. So we do have studies ongoing nationally that are testing CAR T cells against different cancers, including many solid tumors. I think there are challenges we don't have with the hematologic malignancies such as lymphoma, like what Mike has. And the challenges are not only do these cells have to get into the bloodstream to kill the cancers, but they have to get into a very difficult tumor microenvironment, we call it, where the tumor has many signals in turning those T cells off. So again, getting back to basic science and understanding how we regulate these CAR T cells is going to be very important. I don't think we'll see approvals too soon. We'll just see a lot of studies ongoing to understand these cells. There's one other challenge, and that is what are the most important targets on the tumor that these T cells can see. And it's very hard to find specific targets that an antibody can recognize that make that tumor look different from the normal tissue in the case of solid tumors.
So thank all of you attending the webinar for these great questions. I'm going to flip one more of them to Mike Dealey in a second, but as he answers it, we'll launch this poll question you can see on your screen to tee up our next speaker. And Mike, the question I would have for you is you had a wonderful picture in your presentation of being an advocate, interacting with the senator from Maine, Susan Collins, in addition to the wonderful lobsters up in Maine. How are you able, what does it take for someone to approach their representative in Washington or in their own state to advocate for cancer research, and cancer survivors?
Well, the AACR was a major help in this by having the Rally for Cancer here this month. And it allowed me very good access right in their offices in D.C. Up on the Hill to be able to meet with them. The ones that were busy on the floor voting that I couldn't see then, I was able to get meetings with later on. I was fortunate in that all 4 of our legislators up here were very much involved in the $2 billion increase for NIH and very much proponents of cancer research. Other ways to do it is just to Google and get online and to write to hopefully to become aware of when the bills are coming up in Congress and the appropriations are going before the legislatures, and then get your emails and letters into your legislators to make sure they're on board on the to maintain the increases we've enjoyed the last couple of years for cancer research.
All right, thank you. A projected 26.1 million cancer survivors is going to make a wonderful voting block, I'll tell you that. So the question was, what percentage of cervical cancers could be prevented by screening and human papillomavirus or HPV vaccination? And the answer is D, 93%. Most of you got that, actually. That's also in the report, by the way. I would now like to introduce you to Roy Herbst, chair of the AACR's Tobacco and Cancer Subcommittee and a member of the AACR Cancer Progress Report 2018 Steering Committee. Dr. Herbst is Chief of Medical Oncology at Yale Cancer Center, and he's going to talk to us about progress through public policy, being an advocate for cancer research. Dr. Herbst.
Thank you, Bill, and thanks to all of you for tuning in today to learn more about recent progress against cancer. I'm going to share more about the work of the American Association for Cancer Research to support federal funding for cancer research and biomedical science, and to advance science-based public policy in a number of areas, including cancer prevention. So on this next slide, what you can see that it really takes a village. The remarkable progress in fighting cancer that you've just heard about from Liz and Mike was built on basic science, but it depends on this ecosystem, like you see here, of government agencies, academia, and research institutions, private sector stakeholders, a strong pipeline of researchers, philanthropy, and advocacy from the public. But really, we can trace almost every advance back to research funded by the National Institutes of Health, and specifically the National Cancer Institute. And you just heard how important that is and about how important the funding is. If we're going to continue this progress, it's essential that the NIH and NCI receive robust, sustained, and predictable funding from Congress. It also depends on sound, evidence-based policies to promote research and protect the public health. So what I'd like to do now is talk about where we stand with federal funding and highlight the key policy areas of focus, and finally share more about what you can do to advocate for critical investments in cancer research. So if you look at the next slide, you can see after years of stagnant funding, we're finally back on a path of growth. And that's thanks to persistent advocacy efforts by the AACR and many others, coupled with extraordinary bipartisan support in Congress for medical research. If you look at the graph, the green bars on this chart show the NIH budget over the last decade. Starting in fiscal year 2016, Congress committed to reinvesting in medical research through sustained annual increases. Now, as we start the fiscal year 2019, the NIH is 30%, that's $9 billion, above where it was 4 years ago. This is really remarkable and will surely drive continued progress. So for the first time in 22 years, the appropriations bill that funds the NIH has been signed into law on time, no continuing resolutions, and NIH's budget is now at $39.1 billion. This is something to really celebrate, and we thank our champions in Congress for getting this done. If you look at the blue line, it illustrates the trajectory the funding would have had it simply increased at the annual pace of medical inflation since 2005. Thanks to these 4 consecutive years of robust increases, we have almost closed the gap. We want to continue heading in the right direction, and this is where the AACR and all of you come in. I also want to note that the AACR advocates for a strong Food and Drug Administration, including funding for the FDA's Oncology Center of Excellence, also known as the OCE, and well-funded cancer programs at the Center for Disease Control and Prevention. We also have seen medical research in cancer in particular come to the forefront of public and policy discussions through initiatives such as 21st Century Cures, and especially the Beau Biden Cancer Moonshot. The 21st Century Cures Act, which was signed into law in late 2016, does a number of important things to advance medical research and speed the delivery of therapies to patients. As many of you know, perhaps the most notable part of this for the cancer community, the bill provided the $1.8 billion designated funding over 7 years for the Beau Biden Cancer Moonshot program. We are now 3 years into this 7-year funding plan for the Moonshot, and grants are being funded in all 10 areas identified by the NCI Blue Ribbon Panel, which Dr. Jaffe, who you heard from already, co-chaired. This also will accelerate progress in areas where we are poised to make key advances in the near term. In January 2017, the FDA established this Center of Excellence. I'd like to take a moment to talk about the FDA as well, since it is an indispensable partner to the NCI in terms of the continuum from discovery to therapeutic development and approval. As you can see on this slide, it's critical that the FDA receive the annual funding it needs to be well staffed and help speed safe and effective therapies to patients who need them. If you look at this, the FDA OCE does a phenomenal job getting safe and effective therapies approved, because that's what we all want, to get these drugs out there to patients as quickly as possible, from the labs to the clinic, because the patients need them. In just the first year, look at some of these statistics as I'll describe. 17 drug and biologic applications, 32 supplemental drug and biologic applications, and 2 biosimilar applications in oncology. All of this bringing drugs to patients who need them, such as you just heard from Mike. Congress has proposed $20 million for this Oncology Center of Excellence in the year 2019, but appropriations bill that funds the FDA has not yet been signed into law. So it's going to be important to lobby for this fact. If you look at the next slide, you get to the area where I've been most involved with the AACR, and that's tobacco control. The FDA also oversees the regulation of tobacco products. And you can see on this slide all the different types of cancer, 18 different sites where preventable types of cancer death, where we know tobacco can be a major cause. So efforts to curb tobacco use are just so important. And the AACR and other organizations have been working to educate, to promote programs, and to work in this regard across all different groups. While we have made a great deal of progress in reducing tobacco use in this country, we still have to focus on this important area, since more than 1/3 of all cancers can be prevented if people do not use tobacco. And that use is still someplace in the 14 to 15% range and higher in certain communities. Now, something else that's captured our attention recently, and how can you miss this these days, is e-cigarettes. This is an area of hot debate. And if you look at the slide, it's where both the FDA and the AACR have been active in the past several months in the regulation of electronic or e-cigarettes. E-cigarettes are a rapidly emerging tobacco product, with more than 2 million middle and high school students reporting using them in 2017. Their use among U.S. youth is a major public health concern. This trend in youth uptake of these products has led the FDA commissioner to declare youth e-cigarette use a public health epidemic. Because what will happen, of course, is many of these young kids will start using these e-cigarettes. They're filled with nicotine. They'll become addicted to the nicotine. And then, of course, they can cross over to standard combustible cigarettes. It's a major problem, and our organization has been very involved in trying to attack it. If you look at the next slide, here's some discussion of HPV, which was already discussed in the question. The prevention of human papillomavirus, HPV, through vaccination is yet another area where policies can make a big difference. In the U.S., an average of 38,000 HPV-associated cancers were diagnosed annually from 2008 to 2012. Research suggests that HPV vaccination could prevent nearly all cases of cervical cancer and many cases of oral and anal cancer. However, less than 50% of adolescents aged 13 to 17 years were up to date with the recommended HPV series in 2016. I know this firsthand. My daughter and wife came back from the pediatrician where it was not recommended, where they were on the fence whether they should get it or not. And I'm a medical oncologist. This rate of uptake is much lower than occurs for other vaccinations received in adolescents. Thus, development of effective strategies to increase the uptake of HPV vaccines, education, understanding, could have an immense impact on cancer prevention. One recent clinical trial showed an increase in vaccination rates when healthcare providers used a multi-component intervention to facilitate communication with patients and their parents about the benefits of this vaccination. Of course, people are concerned about vaccination. They have to understand the risks and benefits, and that means that caregivers have to understand that, the patients need to understand that, and groups like ours can help with that. Australia has demonstrated the success of HPV vaccination. A government program to vaccinate children against the virus has had tremendous success, so much so that Australia is on track to become the first country to eliminate cervical cancer. Amazing. The AACR has joined all NCI-designated cancer centers and other cancer organizations in calling for the elimination of HPV-related cancers through vaccination. And of course, we couldn't be more supportive. So on the next slide, you see two congressional leaders. Nearly everyone has been touched by cancer, either personally or through the experience of family, member, or friend. There is not a single member of Congress whose life has not been somehow touched by this disease. And you can see two of them here. Like Mike, you can make your voice heard in the fight against cancer by advocating for research at the NIH, and you can have a compelling story to tell. That's what the Congress people like to hear. They want to hear the personal stories. They have their own. Here you see Marc Desaulniers and Ted Poe, both of whom shared their experiences with cancer in this year's report. And we met one of them at the briefing earlier this year. But there are many, many others on Capitol Hill who are with us in this fight. So now, as I conclude, I'd just like to share a few ways for you to get involved. I know there are many people on the line who would like to do that. So here you can see on this slide, AACR advocacy resources. You can sign up for a number of things. The AACR Cancer Policy Monitor, which I receive myself to receive monthly updates on what's happening related to NIH funding and other policy issues that have an impact on cancer research. We need to be aware of what's going on. You can use the AACR Voter Voice Advocacy website, the website's shown, and contact your members of Congress to encourage them to support NIH, FDA, and CDC funding, as well as other science-based public health policies. The next one is really important, as congressional offices want to hear how cancer affects their constituents. They also want to understand the positive impact that research is having in their districts and states. So the Facebook group can certainly help with that. And then there's the Scientist Survivor Program, held twice annually. I've participated in this in the past as a scientist. It's an incredible way to connect survivors and patient advocates with scientists who make up the AACR membership. This unique program is another portal to become involved with the AACR in patient advocacy, both on and off of Capitol Hill. On the next slide, you can see even more ways to get involved. We encourage you to connect with your elected officials through social media and in person. Here are some examples of how you can do that, and you can see on the slides how you can get connected with elected officials, request an in-district meeting with your members of Congress. Here in New Haven, we see our congresswoman quite often, and certainly there are hours to do that. The most powerful tools that we have in advocating for cancer research are the stories of those whose lives, like Mike, were changed by new therapies. As we've heard today, and as this report shows, cancer research is saving lives and improving lives. People are living with cancer, and we are poised to achieve tremendous breakthroughs in the coming years if we have a continued investment in the NIH and NCI. I hope that you will join us as advocates for cancer research funding. I will now turn the webinar back to Dr. Nelson, and I look forward to answering your questions. Thank you.
Thank you, Dr. Herbst. And now we'll turn to answering some questions, and I'll throw out a couple of the first ones. You mentioned that the NIH budget has increased some 30% in the last 4 to 5 years, a great achievement for the world of research advocacy. I guess the question I have for you, is it time to declare victory, build a monument or something? Can you retire? Or what do we need to do moving forward? Where should our advocacy energy be directed to promote cancer research?
No, it's certainly great that it has increased, and this year especially with the added benefits. But we need even more. As you know, you're a cancer center director at our center. We only support a fraction of the research with these monies. It keeps the infrastructure going. It helps researchers get started with some of their grants, and it funds a great deal of programs. But we're going to continue to need more money. The therapy that Mike was on is incredibly expensive. It's working well in his type of cancer, but we want to see that working well in all types of cancer. And that's where we're going to require more funding from the government. Hopefully other organizations will chip in as well. But I think that we're doing better. It's great. It's great for my faculty as I meet with them, because hopefully they'll have a better percentage from the young people going into science. Now we'll be able to get their first grants and their second grant, and they'll stay involved, and they'll be working on all these problems. We have to continue the funding, and I would aspire for even more so that we can really think out of the box innovatively to find the next CAR T therapy to work in perhaps solid tumors, for example.
So one of the questions that's come in is, what about the smoking of marijuana, which is becoming increasingly legalized throughout the country, looked at as a health challenge in the same way you think about smoking tobacco products? Are the risks of smoking marijuana greater than, the same as, less than smoking tobacco products? How does that work out?
Well, certainly, I'm very much in favor of medicinal marijuana, or of course, substances that are not smoked that one takes to help with some of the symptoms of cancer therapy and pain. That said, smoking marijuana, certainly in a recreational way and not in a medical way, certainly does have this similar risks of toxic effects to the lungs and other organs. So certainly one certainly shouldn't use it unless it's for a specific medical reason. Hopefully that's being done in moderation. But yes, I think the more it can be used in non-combustible forms, the better.
Well, and another question, I know that you're working with the tobacco subcommittee. You've been wrestling with the e-cigarette vaping kind of products, sometimes used to aid in smoking cessation, but when marketed to adolescents and young adults and whatnot, can addict people to nicotine. And these e-cigarette technologies may have their own hazards. What's the story with e-cigarettes?
Well, certainly there's no doubt that youth using e-cigarettes is certainly something we should not condone. There's no reason why high school students and even younger need to use these devices that give them very high doses of nicotine. They're totally unregulated. And of course, nicotine is one of the most addictive substances known to man. That said, there's also, there's reports from our group, but of course from the National Academy of Medicine and others that clearly show that there is some harm reduction if you smoke an e-cigarette versus a combustible cigarette. It is preferable. Certainly, what our stand on this is there are many other ways and nicotine replacement substitutes that can be used right now for someone who's smoking combustible cigarettes, patches, gum, and other mechanisms. Certainly, if someone fails all those and wants to turn to an e-cigarette, I would contest that needs to be done with regulated e-cigarettes in the form of clinical trials. So certainly that's something that we'll hopefully see. The nice thing is the Family Tobacco Act has now given the FDA control to regulate e-cigarettes, because actually the nicotine that's in the e-cigarettes is made from tobacco leaves, so it's a tobacco product. So hopefully we'll see regulation, we'll know what's in these cigarettes, what dose of nicotine are people getting. So again, caution. Certainly flavors and attracting kids and advertising this to kids totally needs to stop. In patients who have tried everything else, possibly, but with research and with controlled trials to show the benefit.
How about other tobacco products, the so-called smokeless tobacco products that you don't actually light on fire? What are their hazards?
Well, of course, I treated lung cancer most of my career, but I did work with Keyhang and head and neck cancer for quite some time. There are all sorts of oral cancers that one can develop if you use those agents. And these smokeless products, you put them in your mouth and your gum, you very much at risk. Patients are very much at risk for head and neck cancers, oral cancers. Those are very difficult cancers to treat, quite disfiguring, and those should be avoided as well.
Another one that pops up is, you talked about this a little bit, but maybe we can delve into a little bit more, which is among people who are smoking, who become addicted to tobacco products, what's the best strategy for trying to stop?
Well, right now, I think the best strategy probably is, going in and seeing someone, in a smoking cessation clinic and using some sort of nicotine replacement therapy. Whether it be lozenges or patches, counseling. Here at Yale, we have a large program now where at the time of screening, just a few weeks ago at the World Lung Meeting, there was a study called the Nelson study. I wonder if you're involved. But this study, along with the NLST study, have clearly, there's no doubt that lung cancer screening makes a big difference. So, for example, when patients come in now for screening for lung cancer here, we're hitting them at that time, that teachable moment, to talk about smoking cessation, because most of the patients we screen are people who have smoked for 20, 30 years or the equivalent in many packs of cigarettes. And I think that we're putting them into programs where we're using messaging, videos and counseling, one-to-one counseling. In many cases, this counseling has to be specific to the patients, the community, and the cultural values that they have. But use that counseling along with nicotine replacement, in some cases some of the medications that are involved, Wellbutrin and others that one could use. So there are a number of different ways that one can approach this, but it's so important. The good news is that when the Surgeon General's report came out, the smoking levels in this country were 40–50%. Now we're down to about 14–15%, as we talk about in the report. But here in certain communities like where I live, it could be 20–30%, and it's responsible for 18+ different types of cancer. So really getting these patients, convincing them that they can do this. One of the things we've shown actually very nicely, I think, is that it helps cancer treatment. By smoking, you can affect drug levels of some of the oral tyrosine kinase inhibitors that we're using these days for some of the different types of cancer. And it can also make someone less well, so that they can't tolerate surgery and other therapies as best they can.
So what you're talking about is this seems to be a lot of these data coming out over the last few years about the hazards of continuing to smoke after a cancer diagnosis, not just for what we think of as cigarette smoke related cancers, but for prostate cancer and things. You don't do as well if you are an ongoing smoker during or after treatment as if you stop. So a cancer diagnosis, you would argue, or a cancer screening decision is a great time, a teachable moment to think about how you might stop smoking.
Couldn't agree more.
So one last question for you in the policy and advocacy sphere. In addition to advocating for research funding, the AACR has been pretty effective, as you mentioned, in advocating for structural changes at the Food and Drug Administration when needed, providing input into other health policy things at the Centers for Medicare, Medicaid Services and the like. What do you see in the next year or two on the policy horizon broadly as things that our advocates should have on their mind? We talked a little bit about the financial pressures people undergo when undergoing cancer treatment. What else do you see out there as over the horizon, things we might need to grapple with?
Right. Well, certainly the Oncology Center of Excellence, which the AACR, groups like Friends of Cancer Research and others have pushed for, is just so important because we want to get drugs to the patients as quickly as possible. But I guess if there's one issue that's on the top of my list, it's access. As good as we are, there's a great deal of health disparities, and that was one of the things that was focused on in this year's report. And if you look around the United States, many patients are not getting access to these drugs, or even to the precision medicine we talk about, some of the screening. So, EGFR mutation screening, for example, in lung cancer, the number is 60–70%. So why are 30% of patients not getting access to screening, mutational testing that could change their therapy? So I think that's clearly something that needs to be advocated for. Getting patients drugs. A lot of these drugs, even though they are approved, we still have to get them financially cleared. How can we get patients more drugs? One way to do that is clinical trials. So I would advocate for more clinical trials and getting clinical trials throughout the community, not just at the big cancer centers, which of course will have trials, but 90% of oncology is in the community. So I think it really is going to be important over the next year, try to get all these new treatments we've heard about to the community. Here at Yale, we're trying to set up a cell therapy program. I'm sure you have the same. It's expensive. The hospital is looking carefully at who can get these drugs. If these can help people and improve their lives, we need to get them to as many patients, all patients. And that's going to be something we're going to have to advocate for through CMS, to our insurance companies, to try to find ways to bring these novel life-saving therapies to patients with cancer.
So if we can improve access to high-quality cancer care for everyone in the country, we'll be necessarily improving access to cancer clinical trials, increasing the diversity of participants, and it's the best way to move forward. I couldn't agree more. Thank you, all of you, for joining us today on this webinar. The slides of today's presentations can be sent to you along with a recording of the webinar. In the meantime, feel free to read the Cancer Progress Report by going to www.cancerprogressreport.org. Also, the fall issue of Cancer Today is now available. The magazine is for patients, survivors, caregivers. It offers resources for people with all types of cancer. You can go to www.cancertodaymag.org. And finally, you'll see us launch a webinar survey in just a moment. Please fill out this survey to help us improve your experience and to help us select future topics for this webinar series. We really appreciate your feedback. Thank you all for joining us today, and goodbye.